I remember getting wrecked on a sarcoid question, so I'll put this to rest and completely break it down A to Z for you here. So the question kind of gave a vague history. It mentioned left-sided facial weakness for 3 days. They had flattening of their nasolabial fold, and they were unable to elevate their eyebrow or close their eye completely. They had extreme fatigue, hepatosplenomegaly, and lymphadenopathy. That's it. That's all the question gave me. And so I thought, how on earth is that enough to diagnose sarcoid? Well, here's my breakdown. Number one, it was a young patient. They had facial nerve palsy. Hepatomegaly is seen in 20% of patients with sarcoid, and lymphadenopathy is seen in 40% of patients with sarcoid. And so to diagnose it, the next best step would be an excisional biopsy of a peripheral lymph node to confirm the diagnosis. These patients may also have, and here's where all the things that people really know from step one, is erythema nodosum, uveitis and keratoconjunctivitis sicca, acute polyarthritis, most commonly of the ankles, AV block, also seen with Lyme disease as well as lupus, so be careful here, as well as dilated cardiomyopathy and restrictive cardiomyopathy, central diabetes insipidus, hypercalcemia, as well as elevation in your angiotensin converting enzyme. It'll be elevated in 75% of cases, but it has poor sensitivity and specificity for sarcoid. So the most classic screening finding that everyone knows is that 90% of the time in sarcoid, there's going to be bilateral hilar and mediastinal adenopathy on the chest x-ray. So 90% of the time. You can basically cross off an answer choice if it goes out of the way to say that there's no hilar lymphadenopathy. But if you're very, very convinced otherwise that it's sarcoid, remember, there's 10% of the time that you won't have that hilar lymphadenopathy. So this question did not mention the chest x-ray findings, which made it really tough. They did mention that the lungs were clear to auscultation, so don't let that fool you. To confirm the diagnosis, like we said, you'd do an excisional lymph node biopsy, and it would show non-caseating granulomas. A test-taking tip for you is to not get contrict and put bronchoscopic lung biopsy as the next best step to diagnose, as this is more invasive. It's easier and more appropriate to get a superficial, palpable cervical, axillary, or inguinal lymph node or skin lesion to biopsy. So, don't get confused here. Here's some tricky scenarios. HSV can have focal cranial nerve deficits, but 90% of the time there will be a fever plus or minus altered mental status. They wouldn't have hepatomegaly or lymphadenopathy either. So if you see that facial droop, some people jump on herpes virus causing it, but if there's no fever, it's not going to be herpes virus 90% of the time. Bell's palsy is commonly caused due to the herpes virus, and so if this is the case, your treatment would be glucocorticoids within 3 days. You also can give eye drops too. However, valacyclovir has not really been proven to help the Bell's palsy. A high yield note: if their forehead is spared, meaning you still have forehead and eyebrow movement, your next best step is a CT or MRI of the head, STAT. Forehead sparing is going to indicate a central nervous system cause of facial paralysis. It's not a peripheral neuropathy. It's more likely something more ominous, such as a stroke. Lyme disease can also have cranial nerve 7 palsy in 8% of the cases, but they would not have hepatosplenomegaly either. So Lyme disease and herpes, neither one would have hepatosplenomegaly, and so if you see that, you can cross off those answer choices. Also, if the geography does not match, the diagnosis is usually not going to be Lyme disease on the USMLE. Another one is CNS tuberculosis. They'll usually have prodromal symptoms such as fever, personality change, headache, and nuchal rigidity as well. So, sarcoid can be one of the tough questions on the USMLE. Make sure you know all these common things that you'll see tested, but also be able to identify it from lymphadenopathy, hepatosplenomegaly, extreme fatigue, and a young patient with left-sided facial weakness. And I also want to give you a bonus question here, Lofgren syndrome. And so acute sarcoidosis triad of erythema nodosum, bilateral hilar lymphadenopathy, and acute migratory polyarthralgia, usually with a fever. This triad is 95% specific for Lofgren syndrome. And so the treatment here would be NSAIDs or low-dose colchicine or prednisone. 34. You should suspect mesothelioma if there's a history of cement, tile work, shipping, or automobile brake pad exposure. This will usually affect the pleura with calcifications present, or the peritoneum, or rarely even the tunica vaginalis or pericardium. The parenchyma itself of the lung will be normal with mesothelioma. Make sure you know that. To diagnose, you'll see pleural calcifications. To diagnose mesothelioma, you'll see pleural calcifications on imaging, and thoracentesis with cytology is going to be 35% sensitive. So VATS can help you visualize this as well. The pleural fluid of rheumatoid pleural effusions are very similar to malignant mesothelioma, so make sure you're able to group these together in your mind for the exam. You'll see leukocytes less than 5,000, glucose less than 60, a pH less than 7.3, and high LDH. The treatment is palliative surgery or chemoradiation, as the cure rate is really low. There's about a 1-year life expectancy with malignant mesothelioma. Don't get confused with silicosis. Silicosis will have exposure hints such as miners, sandblasters, foundry workers, and masons. In silicosis, there will usually be upper lobe nodules and lower lobe emphysema. They would not have calcifications or pleural thickening like mesothelioma. So don't just go by the exposure hints. They can kind of throw you off in some high-level questions, but oftentimes if you see sandblasting, you can kind of jump on silicosis. But if they start mentioning stuff like calcifications, you're still leaning more towards mesothelioma because calcifications are not found in silicosis. And here is the light criteria for exudative versus transudative pleural effusions. And so an exudative pleural effusion would have a pleural protein divided by seroprotein number greater than 0.5, or pleural LDH divided by serum LDH greater than 0.6, or a pleural LDH that's over 2/3 the upper limit of normal of the serum LDH. And so exudative causes include tuberculosis and pneumonia, malignancy, rheumatologic disorders, pulmonary embolism, pancreatitis, and post-CABG, whereas transudative causes are more fluid, oncotic, or hydrostatic pressure issues such as heart failure, cirrhosis, including hepatic hydrothorax, nephrotic syndrome, and constrictive pericarditis. 36. Pulmonary arterial hypertension. To diagnose, you can use an echo, and if that's inconclusive, you can get a right heart cath. The treatment is PDE5 inhibitor tadalafil plus or minus an endothelin receptor antagonist such as bosentan, and you can use both together if the patient is still symptomatic. If a patient is going to have an elective procedure, make sure that you have counseled them about smoking cessation at least 4 weeks prior, because actually stopping to smoke within the 4-week period prior to surgery increases your risk of postoperative pulmonary complications. So you need at least 4 weeks of cessation for the benefit to be tangible. 38. Pneumothorax. The treatment, if the patient is in cardiac arrest or it's impending or there's severe hypertension or JVD, then you could consider a needle decompression and then a chest tube, just because the needle decompression is going to be a little bit faster. If the patient is stable, you'd go straight to chest tube. In real life, I have never done a needle decompression. I'm going to be honest. We almost always just go straight to chest tubes. Whether it's in the ER, whether it's in the OR, we just go straight to chest tube because we can do them relatively quickly. A tricky question for you here is, what's the best initial test to diagnose this pneumothorax in a trauma? Well, the answer is going to be a bedside ultrasound, and you want to look for lung slide. This will have over 90% sensitivity and specificity, whereas a chest x-ray is like 50% specificity and sensitivity. And so the best initial test is going to be a bedside ultrasound.